Good afternoon, everyone. My name is Mia Pappas. I'm filling in for Dr. Jerkovitz this afternoon. Welcome to the Innovative Discovery Series, this 28th day of April. A few reminders. So first, we continue extending CME credits for our Tech Talks and our ID Series presentations. We will distribute the information via email to those that registered for today's event, or you can obtain the information from Deborah Reese at Christiana Care, and her email address will be in the chat box. In 2 weeks, mark your calendars for Thursday, May 12th. We hope you join us again when our speaker, Dr. Craig Pollack from Johns Hopkins University, will be speaking with us on housing policy as a tool to improve health equity. But this afternoon, I am delighted to introduce our speaker, Dr. AnnieMarie Brescia from the Division of Rheumatology at Nemours Children's Health, who will be talking about the prognosis in juvenile idiopathic arthritis. Dr. Brescia has a long and outstanding CV, but I'm going to go through some really interesting highlights. AnnieMarie obtained a bachelor's degree in chemistry from Fordham University, after which she conducted synthetic organic chemistry research for which she holds 2 U.S. patents. Super cool. Then, while pursuing graduate studies in chemistry, she decided to enroll in medical school, which we are all very happy about, graduating from the NYU School of Medicine and then completing her internship and residency training in pediatrics at St. Christopher's Hospital for Children in Philadelphia. She also completed a research fellowship at the National Institute of Arthritis, Musculoskeletal, and Skin Research at the NIH, and her Pediatric Rheumatology Clinical Fellowship at Thomas Jefferson University, Nemours Children's Health. She then became faculty and is currently chief of the Division of Pediatric Rheumatology at Nemours. She's board certified in both general pediatrics and pediatric rheumatology and divides her time between clinical care and translational research, and is recently a pilot grant recipient of the Delaware CTR. She's also the fellowship director of the Pediatric Rheumatology Training Program at Thomas Jefferson University and is a lifelong learner. In 2018, she completed a certificate in bioinformatics at the University of Delaware, if she didn't already have a full plate. Dr. Brescia is currently on several hospital committees, including the Graduate Medical Education and Residency Selection Committee, and she is committed to ensuring excellent training for future rheumatologists and outstanding care for patients. She's received numerous awards and recognition, such as Delaware's Top Doc in Pediatric Rheumatology, as well as the Castle Connolly Exceptional Women in Medicine Award for 3 years in a row. Her research interests, which we will learn about this afternoon, focus on juvenile idiopathic arthritis, or JIA. She has several ongoing projects investigating the identification of biomarkers to predict the likely course of disease, which will allow physicians to give patients and families more information on which to base treatment decisions and discover new treatment options. So join me in welcoming Dr. Brescia this afternoon. AnnieMarie, take it away.
Thank you, Dr. Pappas. That was lovely. I'll have to shorten that for the next time I have to submit something. Okay, so today we're talking about my favorite topic in the whole world, juvenile idiopathic arthritis. And I have nothing to disclose. Of course, in rheumatology, we use lots of off-label meds, and so I will discuss some non-FDA approved indications. So this is what we're going to talk about today. I am a clinician and a translational researcher. The first 2/3 of this talk is all clinical stuff, more than anything that you ever wanted to know about arthritis. And the last 1/3 will be on our research, our current and past Accel projects. And so I hope you will stick with me for the whole thing. So JIA, or juvenile idiopathic arthritis, is the most common type of arthritis in kids. And you can see here the typical child with arthritis. Let me see if my little mouse will work. Okay, so this kid, he's pretty happy. He still plays, but he has a big swollen knee, and he's not so happy. And we'll talk about this type of arthritis called oligoarticular. And then there's other kids that have what's called polyarticular, and you can see in this picture on You're right that all the what are called PIPs, proximal interphalangeal joints, are swollen, and some of the MCPs, metacarpal phalangeal joints, and especially you can see the IPs, interphalangeal joints, on the thumb. And so many people don't know kids can get arthritis, but actually the most common age of onset is 1 to 3 years of age. But any child diagnosed with arthritis under 16 years of age, we call JIA. And the immune system is basically thinking the lining of the joint, called the synovium, is foreign and attacking it, much like lots of other autoimmune diseases like diabetes, Crohn's disease. So symptoms of arthritis are either swelling, it's easy when they're swelling, or at least two symptoms: warmth, pain on range of motion, or restriction, loss of the range of motion. Many people have arthralgias, just joint discomfort, but they have no objective evidence of inflammation. Some patients with JIA may have some other systemic features like weight loss and fatigue, but many patients do not. And we do not call it JIA until it's been present for more than 6 weeks, which I'll go into why. The pain is more like a stiffness and aching. They're stiff in the morning, they might be stiff after a car ride. And all joints can be involved, even small joints and the TMJ, but large joints are more often involved, knees, hips. So we'll do a bunch of cases just to learn about the various subtypes of juvenile idiopathic arthritis. So the first case is a 3-year-old little boy who started limping and had a left knee swollen about 3 weeks before you see them. The limp persisted even though the swelling got a little better. This never happened to him before, and no other joints are bothering him. On review of systems, nothing concerning at all. No weight loss, no rashes. There is a great aunt with rheumatoid arthritis, or RA. And on exam, you find that the left knee is swollen and a little bit warm. So this has a pretty big differential. Since it's only 3 weeks in duration, you don't want to call it JIA yet because it has to be present for 6 weeks. And the reason why is there are many other things that can present with a swollen joint that are not chronic juvenile idiopathic arthritis. So hopefully not by your exam, but this could be a septic joint. They would usually present within 24, 48 hours with a hot, red, swollen, doesn't want to move joint, if there were actually bacteria in that joint. It could be a reactive arthritis, a post-infectious arthritis. So they had some sort of infection a week ago, now they got a swollen joint. It will go away in less than 6 weeks, and that's a reactive arthritis. In this area, certainly could be Lyme arthritis, right? Can be other uncommon things, lupus, leukemia, unfortunately. Could be trauma, but they would probably tell you that history. Could be the beginning of an inflammatory bowel disease. Actually, I'm talking to the GI fellows tomorrow morning all about the rheumatic considerations of inflammatory bowel disease, meaning Crohn's and ulcerative colitis. And so patients can present with arthritis even years before they have the gut disease. And so this arthritis could be the beginning of an inflammatory bowel disease. Also celiac, which is not on this, where patients cannot have gluten. Other inflammation of blood vessels could have a periarthritis, meaning swelling outside the joint but over the joint, or acute rheumatic fever from strep. If the patient didn't have swelling, now this little guy had swelling, but if they didn't have swelling and just had pain, you look for other things like hypermobile joints, very bendy people, fibromyalgia, which is, chronic diffuse amplified pain, or a complex regional pain syndrome, meaning pain right in that area. So post-infectious arthritis, as we talked about briefly, there's lots of infections associated with post-infectious arthritis, even gut infections like Clostridium difficile or C. diff. The arthritis after infections is a much shorter duration, so it's usually gone in 2 weeks, and almost all gone by 6 weeks, which is one of the reasons that you don't call someone a chronic arthritis like JIA until after 6 weeks. And there's another entity called a transient synovitis, which is more often in a hip in young boys. So this patient, what workup might you do? You have a 3-year-old with 3 weeks of a left knee arthritis. You would get Lyme definitely in this area. You would get an ANA, which I'll talk about. This has to do with prognosis in juvenile arthritis, not diagnosis. You would probably x-ray that knee, because what if there's something in the bone next to the joint causing this swelling? You might MRI. Also could be something in the bone, in the soft tissues that's causing this. And an eye exam, because patients with chronic arthritis can have eye inflammation, which we will also go into briefly later. So this, as 3 more weeks go by and it persists for 6 weeks, this little guy has oligoarticular subtype, and that just means 4 or fewer joints in the first 6 months of disease. It's usually in little females. Most patients are ANA positive, and about 1/3 of patients can have the eye inflammation. The knees and the ankles are the most often involved. This is a little Baker's cyst with a smiley face on it from clinic, and that is so much fluid in the joint that it popped out the back of the joint, and this can rupture and go into the calf, which is not happy and painful. And again, you can see swollen knee on this child and this little friend from the ACR slide collection, which this is what the typical patient with oligoarticular arthritis will look like. Now, your next case, you have a little 19-month-old, so she's not even 2 years old. This has been left knee swollen and warm for 10 weeks. Already had eye exam, no inflammation, no weight loss. In the family, someone has hyperthyroidism and someone else has an autoimmune eye disease, not otherwise defined. And on this patient, you do find that the knee is stuck bent, a 20-degree flexion contracture, right? So your knee should extend fully, which would be 180 degrees, but this patient is lacking 20 degrees of extension. She's limping, it's a little warm, it's tender, and her ANA is 1 to 640, which is moderately elevated. Her marker of inflammation, called the SED rate, normal is less than 20. Hers is a little bit elevated at 31. And another marker of inflammation is normal, and her CBC is normal. She's not anemic. So this little one just had a steroid put right in that joint. Like you drain the fluid and put a steroid in to shrink the inflammation. The patient went into remission and was completely discharged and gone from follow-up, doing amazing, for 6 years. 6 years later, they presented with just complaints of right wrist pain and swelling, but on exam, you actually find many joints involved: fingers, knee, ankle, toes. And now this patient has 7 joints involved at more than 6 months after the onset of disease. And this is my favorite subtype, and is the type that my research that we'll talk about at the end is about. This is called an oligoarticular subtype extended. And this is they usually extend within the first 2 years after the onset of their arthritis, but it can be even years later. And what's most important about this type, extended, which means they had 4 or fewer joints in the first 6 months, but years later they recruit 5 or more joints, is once they present again as extended, they're very difficult to get under control. And that's not good, because by the time you see them back and they've extended, it's really hard. They've already have some damage. It's like things have been set in motion with the immune system that makes it really difficult to get under control. There have been some clinical predictors to try to see who will extend, listed here, but they're not so accurate at predicting who will extend, and only about 12% of these patients will go into remission, whereas if they had stayed as a persistent 4 or fewer joints, there's a 65% chance they will go into remission. So this is a really tricky category and near and dear to my heart. So the next one is, you see an 8-year-old female who only, had a trauma. They thought it was just an injury to the left wrist, but it continued to hurt. MRI was done, and there's erosions, which means holes being eaten into the bones. She's stiff in the morning for an hour. Some other joints are also bothering her. There is nothing exciting on the family history, but when you do the exam, you see many, many joints, swollen, restricted range of motion, especially small joints of the hands, the ankles, the toes. Compare this to this 11-year-old female. Very similar story, stiff in the morning for an hour. Her joint pain's been longer, about a year. In the family history, there are some autoimmune things. Vitiligo and lupus are in the family. When you examine the patient, she does have hypopigmented macules, which could be consistent with vitiligo. And on exam, you find a lot of joint restriction, swelling of the knees, ankles swollen, wrists swollen. And on your labs, she's inflamed. Her SED rate, remember we said normal's less than 20. It's up a little. She's a little anemic, which can be from chronic inflammation. Her ANA is negative, good, in a lower category to have eye inflammation. But her rheumatoid factor, normal is less than 13. Hers is 254, less than 14. And her ACE level, which is something for sarcoid, another form of arthritis and lung disease, is normal. So both of these young ladies have the polyarticular subtype. And the reason why I bring up both of them is a very important distinction, and why we call this juvenile idiopathic arthritis instead of juvenile rheumatoid arthritis is only about 5 to 10% of children with arthritis will have the rheumatoid factor, which is one of the things we think of for adult rheumatoid arthritis. So having a negative rheumatoid factor is actually expected in JIA. Unfortunately, if they have a positive rheumatoid factor, it's really much more like very early onset adult rheumatoid arthritis and can be severely erosive and very difficult to get under control. So these are the two subtypes of the polyarticular. The usual, they don't have rheumatoid factor, you still treat them aggressively, and the small percentage are rheumatoid factor positive and a newer antibody called the CCP antibody or cyclic citrullinated peptide antibody. If those are positive, you really have to treat very aggressively because the presumption is that this is early onset, lifelong adult rheumatoid arthritis. And again, this is what a typical hand would look like that we saw before. And patients can have this in any type of arthritis, but particularly the polys. If they have TMJ arthritis, they can have underdevelopment of the mandible, so hypomandible, and retrognathia, meaning the chin is pushed back a little because the mandible is small. And so patients don't like that. So now, your fifth patient, you see a 9-year-old male who's had many years of bilateral ankle pain, was originally diagnosed with Lyme, but he just didn't get better. He's stiff for an hour in the morning. He moves like a little man in the morning. Pain in his cervical spine, lumbar spine, and the sacroiliac joints. He has difficulty with activities of daily living. He doesn't feel that great overall. In the family, there's low thyroid and Raynaud's and inflammatory bowel disease. On exam, you find many things. He has pain on range of motion of his spine. His sacroiliac joints are tender. You don't really find much arthritis, but you find lots of discomfort on the insertion of ligaments and tendons on bones. And on your labs, you find that he is HLA-B27 positive. So this subtype is a special subtype of JIA called enthesitis-related subtype, or ERA. And they can have both arthritis, which is the swollen joint that we talked about, and enthesitis, which is pain at the insertion of tendons, ligaments, capsules onto bones, or one of them alone. So he only has enthesitis, but he has sacroiliac tenderness. He's HLA B27 positive. He's a male over 6 years of age, and he does have a family history of inflammatory bowel disease, although we don't know if that patient has sacroiliitis. So this would be your typical story for an enthesitis-related arthritis. Oh, sorry, and here's some more info about it. So they will have, we include in this juvenile ankylosing spondylitis, inflammatory bowel disease-related arthropathy. They often have loss of mobility of the back. They can have peripheral arthritis, meaning not the spine, preceding the axial arthritis, which means the spine, cervical, thoracic, lumbar, or sacroiliac joint involvement. And we see over here these x-rays of the sacroiliac joints. On this close-up, you can see the widening and even the funny irregularity or erosions or eating into the bone more often on the iliac side of the bone than on the sacrum. And they can also get healing sclerosis, which is kind of this more white line that you see. So, patient 6. I hope you're not tired of patients, but I'm almost done the patients. So this is, this young man is 15 years old, and he comes with pain in the plantar aspect of his left second toe, and he's in a boot when he comes to see you. The right foot then began bothering him in the same spot. Then the ankles and toes became swollen. Then his thumbs swollen. His back is stiff in the morning, and he feels better when he moves. So inflammatory back pain is something we look for, which is greater than 3 months, most mornings, discomfort in your back that improves with movement, right? That's inflammatory back pain. If you have an injury, your back is worse with activity, right? But these patients, if you have inflammatory back pain, it feels better when you start moving. So in the family, there's unfortunately lots of things. Low thyroid, rheumatoid arthritis, dad has psoriasis and possible psoriatic arthritis, and a maternal uncle has an undefined colitis, so not a definite inflammatory bowel disease. On exam, you find lots of swollen things, something called dactylitis, which is diffuse swelling where all the soft tissues and the tendons and the joints are involved, and the ankles are very swollen. His labs are a little bit boring. He doesn't have the HLA-B27 gene. His markers of inflammation is normal, but this is actually psoriatic subtype. And so the arthritis of this patient doesn't have psoriasis. His first degree relative, his dad, has psoriasis. But you can have the arthritis even years before the skin manifestation of psoriasis shows up. It's typically more lower extremity, but it can also be small joints of the hands and upper extremity joints. We talked about dactylitis or sausage digits, so much more than the joint is involved here, right? The tendons, the ligaments, the soft tissues, the tendon sheath are involved. If you have arthritis and a first degree relative with psoriasis and dactylitis, which is this, or nail pitting seen here, even without the skin rash of psoriasis, the diagnosis of psoriatic arthritis is made, which is what this young man had. Oh, sorry, here's dactylitis, so one big fat toe. It's very cute, but painful. And then they get something called tarsitis, which all the little joints in the midfoot are inflamed. It's very painful to walk, as you can imagine. Okay, last patient, I believe. So this is a 2-year-old male, daily fever for 2 weeks, and a faint rash that is called salmon-colored. I don't know that it's really salmon-colored. And the rash becomes more prominent when the patient has a fever. 2 weeks ago, they said their wrist hurt. Now he's refusing to walk. He's irritable. He won't eat. On exam, you find arthritis plus rash, and you see an elevated white blood cell count, anemia, elevated platelet count, which can be from inflammation, elevated inflammatory markers, something called a ferritin, another acute phase reactant, meaning it goes up during inflammation, is elevated. And this is what is called systemic onset subtype. So it's a little different than the other types of arthritis. because they have fever and rash. And so they can be a little difficult to get under control, but we'll talk about their treatment. They usually have at least 2 weeks of high spiking fevers, but honestly, if it looks like systemic JIA, we don't make the patient wait for 2 weeks of fevers before we start treating them. And this, more of the rash. These are some from clinic, some from the ACR slide collection. So it's a very evanescent rash. So it might not be there. The patient feels fine in the morning, no rash, no fever. Come late afternoon, all of a sudden the fever goes spiking up, the patient's miserable, and the rash appears. And this is thought to be due to the release of cytokines, particularly interleukin-1 and interleukin-6, during the fever. So you actually just did a rheumatology fellowship. Like, you just learned all of the 7 subtypes. The last one, of course, is undifferentiated arthritis, meaning you have more than one category. Like, maybe you have inflammatory bowel disease, but your parent has psoriasis. Well, do I call you psoriatic arthritis, or do I call you enthesitis-related arthritis? I don't know. I'm going to have to call you undifferentiated. But so this is the breakdown. Luckily, oligoarticular arthritis, which is the most straightforward to treat, is the biggest group of patients. And so we try at 6 months to put patients into one of these categories, because there are slight deviations in treatment, not in the very early treatment, but some subtleties as you go by. So what kind of imaging might we do? X-rays. Sometimes we do ultrasounds of the joints, MRIs. We don't do that many bone scans anymore now that we have MRIs, which has no radiation, as opposed to a bone scan. We do some basic labs, and then other labs as indicated, as we talked about. We would check for Lyme, ANA, looking for their risk of eye involvement. If we think they're early onset adult rheumatoid arthritis, we will check our rheumatoid factor and CCP. And if we think they're more like an enthesitis-related arthritis, we will get an HLA-B27. So what are the goals of treatment in JIA? Of course, in any disease, you want to maximize the efficacy of your treatment, but minimize the side effects. Long-term, of course, we don't want the patient to be in pain, but long-term, our real goal is to maintain their function, prevent deformities, and control the inflammation. To do this, we know that irreversible damage like erosions can happen early. And so when I started doing this many, many years ago, the style was to kind of wave them on anti-inflammatories for months before you started disease-modifying anti-rheumatic drugs, which we'll talk about in a second. That paradigm has completely shifted to treat early on very definitively, and then get the patients off the medicines when you can. But you want to shut down the inflammation early, and you really want to promote normal growth. And our new paradigm, we believe that remission is possible, and it is. We get patients off and discharge them. So our initial treatment is plain old non-steroidal anti-inflammatories like ibuprofen, but we use a little bit fancier prescription ones, but sometimes we use ibuprofen. Unfortunately, they have untoward side effects. What you're seeing here is one of my beautiful patients who got a rare side effect called pseudoporphyria. So for everyone to know, if you're on any NSAID, very good sunscreen. Any NSAID, including ibuprofen, can make you sensitive to the sun, and you can get a blister and a shallow scar from it. It's rare, but it happens. So if we start with anti-inflammatories, then we do intra-articular steroid injections, or maybe just steroid injections if they have one joint and we think we can get it under control. Then if those don't work very quickly, like within 6 weeks, we move on to the DMARDs, which are disease-modifying anti-rheumatic drugs. And those were defined by drugs that help slow the X-ray progression of disease, meaning the thinning of the bones next to the joint space narrowing from loss of cartilage, and erosions into the bones that you can see on X-ray. So methotrexate is the most commonly used, and this is a weekly medication, either shots or pills. And then we use some of these other medicines. We also use leflunomide or Arava. This is only approved for adult RA, but we do use it if they can't tolerate methotrexate. And then you've probably seen every ad in the world for these medications. These are the biologics that are used for JIA. On the left side of your screen, I have the FDA approved, that specifically have the approval for juvenile idiopathic arthritis. Most of them are approved down to 2 years of age. The early ones you've probably seen on TV, etanercept and now adalimumab. Golimumab was just approved for kids. And we tend to use these first, and then we move on to these other medications. Canakinumab is only approved for systemic JIA, and secukinumab is only approved for ERA and psoriatic arthritis. But some patients, believe it or not, exhaust all these medicines. Either they don't work from the beginning, or they work and the body starts to make anti-adalimumab antibodies and eats the medicine. And then once they've gone through or can't tolerate these that are approved, we move on and use the non-FDA approved medications for JIA, usually stealing from what's approved for adult rheumatoid arthritis, but just hasn't been tested in kids. So our usual treatment algorithm, if you're oligoarticular, as we said, you might get something simple, steroid injection, non-steroidal anti-inflammatory, then move on to methotrexate if it doesn't work. Then the standard is to go to one of those anti-TNF agents, mostly because they've been approved the longest. Etanercept was approved for kids in 1998, so that one's been on the market the longest. So we tend to go for those first, and then you can pick from any of the other approved ones. For polyarticular, non-steroidals and methotrexate would be started at the very first visit, and by 3 months, if they haven't significantly improved or if they're worsening in that time, you would move right on to an anti-TNF agent. And then one of the others, systemic JIA, the one with fever and rash, is its own little category. We use a specific NSAID called indomethacin. They may or may not need steroids to shut things down. And then we block IL-1 and IL-6 in these patients because those have been shown to work the best for the systemic JIA. Okay, so what are some pediatric issues? Eye involvement, which we'll talk about, nutrition from TMJ arthritis, growth disturbances, there can be leg length discrepancies, some altered ossification centers, thinning of the bones if they needed steroids chronically or because of disease activity. All these cytokines are not that great for the mineralization of your bones. And of course, there are psychosocial issues and disability that can occur. So the eye, I'm going to speed up a little because I still want to tell you about our research, of course. So the eye can have, unfortunately, what's called an insidious uveitis, which means silent eye inflammation, that the patient does not notice loss of vision and they don't have a red eye or eye pain. So the patients go for routine screening, like every 3 months if they're ANA positive, because they're at high risk for this silent eye inflammation. Very treatable with the same meds if you catch it early. But if you let it go on, you can have unwanted complications like cataracts, glaucoma, and impaired vision, of course. As the years go by without uveitis developing, their risk goes way down. So here's an eye. I'm not going to go into all of this. And this is the unwanted side effects. So this is a hypopyon, which is white cells in the bottom of the anterior chamber from all this inflammation. And these are sneaky eye. You can see the pupil doesn't react correctly because the iris is tacked down to the lens because of inflammation. And this is band keratopathy. So this is deposition of calcium in Bowman's capsule, and you can see it's going right across the pupil. This is not good for the patient. And so we try to avoid those by catching it early through screening and treating, but it's very treatable, as I said. So psychosocial aspects, unfortunately, there are increased psychiatric disorders in patients with JIA. 15% have depressive disorders, and you can see 5% with adjustment disorders, and these are linked to length of their illness, difficulties with learning, and kind of being left out of some leisure activities because maybe they can't do something. The goals are to keep things as normal as possible, both in the home and at school. So the patient should have all the same expectations as the other kids in the house. So they can do a chore. They shouldn't be like excused from things. Then they think they don't have to do anything. And in school, we do ask for certain accommodations, but we really try to encourage the patients to stay in school, do gym to their tolerance, anything they need to help them succeed, like maybe they need the elevator, maybe they need to leave class 5 minutes early so they don't get run over in the hallway, then we will ask for those kind of accommodations. And most schools are actually really accommodating and help the kids succeed in school and at home. Oh, good. We get to talk about my research. Okay, so my Accel project, I've been very fortunate to have both an MRDA, which really helped me write the first pilot, and then they very graciously allowed me to put in like kind of an extension or renewal of that pilot. And so I'm going to tell you a little bit about both areas of the work, because they fed into each other. So as you know, we just talked about JIA, which I love. And there's a risk of permanent joint damage. And one of these big risks is when the patient misbehaves a little. They look like they're just going to have oligoarticular arthritis, 4 or fewer joints in the first 6 months, and you call them oligoarticular and you treat them nicely. And later, maybe in the first 2 years, but maybe even 7 years later, they extend and start recruiting more joints. And that is actually very different. It's a little easier to get someone who has polyarticular involvement right from the beginning. We treat them more aggressively because we treat what we see. And those patients over here in the polyarticular actually have a better outcome as far as health-related quality of life and need for joint replacements than those in the extended. And we think it's because as soon as we see that you have many joints involved, we accelerate starting methotrexate and the biologic medicines. Whereas this patient, by the time they show us that they're extending, we're a little bit behind the 8 ball. So what's really important is to try to predict at this time which patients will go over to this extension before you can see it on exam and before the patient notices, of course. And so we study the fibroblast-like synoviocytes, or the FLS, and the reason why is they've been shown, they line the joint, and they've been shown to be a really important cell in rheumatoid arthritis. They are known to have roles in inflammation and joint damage. You know, they release MMPs, matrix metalloproteinases, which degrade the extracellular matrix. They release cytokines. They're gatekeepers. They invite other cells into the joint that perpetuate the damage. And we know that FLSs are pluripotent cells, right? So they are thought to be derived from mesenchymal stem cells and can differentiate into all different types of cells. So if this is a biopsy from the lining of an inflamed joint, these FLSs layers should only be about 2 cell layers thick. You can see in the inflamed joint, they're all heaped up. And so all those cells are doing not nice things for your joint, releasing fluids, releasing damaging cytokines. And this is what they look like in culture. They look like fibroblasts. So we used gene expression by microarray a while ago and protein arrays. We've been using them to develop a biomarker panel on synovial fluid. After we identified and validated with internal sources, we then validated the candidate markers on an external cohort. When we looked at just our Nemours cohort, there was reasonable specificity of all the biomarkers, with CD14 being the most specific at 86%, and IL-6 as the most sensitive for accurately predicting which synovial fluid came from patients who would ultimately extend. So all these samples were from prior to extension, when we didn't know clinically what the patient would do. When we used the Cincinnati cohort, which had 23 patients who were persistent oligoarticular and 25 patients who were pre-extension, but we know those patients' disease course that they ultimately extend. Again, CD14 was the most specific, and IL-6, which was the most sensitive. When we combine both cohorts' data, that pattern held. Oh, sorry. Then we decided to enrich our panel by adding additional candidate biomarkers. So we assume all our cells have the same characteristics because they're isolated from synovial fluid. But as we said, FLSs, fibroblast-like synoviocytes, are pluripotent, meaning they can become many different kinds of cells. And based on our previous studies from our lab, we know that they have characteristics of cartilage-like cells. So we use single-cell RNA-seq to determine if the FLS are heterogeneous, meaning they have characteristics not just of fibroblast-like synoviocytes, but of other cell types. So we isolated FLS from the synovial fluid. In this experiment, we used 3 oligoarticular, which is 4 or fewer joints at 6 months, 3 pre-extension. They will have a polyarticular course later, but the fluid was from before they extended, and 3 polyarticular, which meaning right from the beginning, and at the time of this sample, they had 5 joints involved at 6 months. If these were all a uniform cell type, we should have had a single cluster of cells identified by a single color, but this ended up being several clusters identified by different colors, demonstrating that the FLSs are actually comprised of many different subpopulations of cells, making them heterogeneous. The cells that grouped into a single color have similar gene expression to each other, and they differ in their gene expression from any neighboring clusters. So each group of replicates was used as a separate input into something called Seurat data analysis package, which is made by Bioconductor. It pre-processes the data with total expression normalization and removes any unwanted sources of variation. And Seurat applies a graph-based clustering approach to partition the cells into what are called communities. When Seurat performs, this is a UMAP. The last one was a Tisney slide for any of who does single-cell RNA-seq. This, when it does the UMAP dimensionality reduction, the graph-based clusters will co-localize in the projection, so you can see a one-dimensional image of the cells and correlate this to distance to the other cells. So in the oligo samples shown on your left, all the communities seem to kind of co-localize together. They're all squished together. Well, in the polyarticular samples, we start to see the most separation among the cell communities. So from this data, we concluded that increases in heterogeneity of the FLS correlates to the distance between the cell cultures, and that separation corresponds to progression to a more severe disease course, from oligo to extended to polyarticular. These cells are then automatically annotated using single R data package, also from Bioconductor, and they take a reference data set of cells, which in this instance was the human primary cell atlas data, and they labels the new cells based on the similarity to that reference set, and it gives a cell count of each subpopulation, and you can see the different cell types that are identified. And so then the Seurat integrated analysis was done to compare the JIA subtypes, and based on these common sources of variation, allowed identification of shared populations across the data set and do downstream comparative analysis. While many cell-like subpopulations were identified, as you can see, there were 3 most populated cell type subpopulations across the 3 subtypes, and those were chondrocyte-like, fibroblast-like, and smooth muscle cell-like cells. So, this is going to the bottom of the page, but okay. So many genes overlapped when we look at what's in the different oligoarticular, extended to be or pre-extension, and polyarticular. But the unique genetic fingerprint of these subpopulations shows that even in a single uniformed cluster of cell-like cells, like even within the chondrocyte-like, the fibroblast-like, and the smooth muscle cell-like, there is heterogeneity between the subtypes as well. Our goal is to see if these differences translate into protein expression and if these proteins can be measured on synovial fluid from patients with JIA. We're hoping that these differences will correlate to the various subtypes of JIA and could potentially be used as biomarkers to determine which course a JIA patient will follow. So based on those preliminary single-cell RNA-seq data, we proposed 6 additional biomarkers to our first group of biomarkers. And they're listed here, using ELISA, we're measuring the expression levels of these candidate biomarkers in synovial fluid from both our biobank or repository, the Cincinnati Children's Hospital samples that they shared with us, and we're trying to see if any of these biomarkers could be combined with the early panel to see if a multiplex analysis would be more appropriate and more effective at differentiating which patient would fall into one subtype, each subtype. And so we've tested 3 of these 6 new biomarkers. So far, our goal, as we said, was to translate the expression of these secreted proteins by the chondrocyte subpopulation to our FLS to detection in synovial fluid instead of from cultured cell. As expected, aggrecan, or ACAN, and collagen 1 were overexpressed in the synovial fluid from 37 persistence and 32 samples in the extended to be. And VCAM, vascular cell adhesion molecule, was overexpressed in the synovial fluid of the extended to be when compared to the persistent. And so if we can translate these markers from the FLS gene expression to the total protein, secreted protein expression in the synovial fluid, that will allow us to continue our plans of conducting a linear discriminant analysis to determine if the markers in combination can consistently predict the JIA subtypes. This will let us move from isolating the FLS, which is not really practical as a clinical application, to testing the synovial fluid, which will be more applicable to patient care. So we also have a second aim, which is to define the clinically relevant subpopulations of fibroblast-like synoviocytes on the synovial fluid. And so we hypothesized that these distinct FLS subpopulations would correlate with the clinical outcome, and our plan is to use flow cytometry on synovial fluid of newly obtained samples to characterize the cell population, determine the percentage of the 3 distinct cell subpopulations, fibroblast-like, chondrocyte-like, and smooth muscle cell-like, and then predict which patient will extend and follow them over time. That is the second part of our study. So taking the 3 subpopulations that we saw, we calculated the percentage of each cell type within each subtype of JIA based on the total number of cells and determined statistical significance between them. Each bar is the cell type percentage. The blue bar is from oligoarticular samples, the orange is from the pre-extended samples, and the gray represents the polyarticular samples. And we see that the oligoarticular have significantly more cells identified as smooth muscle cells than the polyarticular do. And pre-extension have more cells identified as fibroblast-like than when compared to oligoarticular. This was not significant, I think, because of the error bars. And polyarticular had significantly more cells identified as chondrocyte-like when compared to either the oligoarticular or the pre-extension. So as the cells evolve towards a more chondrocyte-like characteristics, their FLS subpopulation and smooth muscle cell population seem to decrease, particularly between oligoarticular and polyarticular. Our goal is to correlate these subpopulations of the subtypes to their clinical outcome, specifically whether at the time of oligoarticular can we predict if they'll stay persistent or take an extended course. To do this, we'll employ flow cytometry to establish the immunophenotype, or what proteins are on the cell surface of our subpopulation of interest, and we'll use also FACS, or flow, being used to sort the cells to try to identify a specific cell type. Now, this work is not going as amazingly as we would have liked. We have been developing a panel of surface markers for flow cytometry. However, our panel of well-known traditional markers had quite a bit of expression overlap between normal cell lines. And so we are revisiting our single-cell RNA-seq data and reviewing different manuscripts in which they are specific to chondrocytes, fibroblast-like, and smooth muscle cell subpopulations to expand our antibody panel to try to find markers more specific for each subpopulation. And we're currently investigating which ones will work. We do expect overlap because all the cells are fibroblast-like synoviocytes, but they've taken on characteristics of these subpopulations. So it's turning out to be trickier than we thought. So in summary, we know that the fibroblast-like synoviocytes are key effector cells in RA, and they have an aggressive phenotype. We think that they also are a major determinant in the disease extension in JIA. We have found that each JIA subtype that we looked at, specifically persistent oligo, extended oligo, and polyarticular, have multiple subpopulations of cells which comprise the single population of FLSs. And we think that we can use these percentages of the cell subpopulation to predict extension, and that differences in the gene expression within the subpopulation based on your subtype could possibly be added to our biomarker panel to help make it more robust. And the good thing is that the protein expression can be measured on synovial fluid for any genes that encode secreted proteins, and those will be very useful for us moving forward. Oh, so this is a community engaged project, and it just started. It's a 2-year project, and I guess the first year is wrapping up in June. And so we need to hear from patients and families, how they would like to receive prognostic information. It's great if I tell them everything I learned, but if they don't want to know it or don't know what to do with it, it's not helpful for them. And so we're forming a small community advisory panel of 3 to 4 parents of children with JIA. And I'm also inviting the executive director of the Arthritis Foundation. The plan is quarterly, probably 30-minute virtual meetings to hear what they want to know that would really be relevant to them and how they're able to hear it. So unfortunately, Arthritis Foundation went through several executive directors through COVID, but now has a brand new, lovely executive director. I am on the medical board, the executive board of the Arthritis Foundation of Delaware, and so I will entreat her to join me. And the only 2 people I've asked both said yes. One is a parent and one former patient. They said yes immediately. So my little community engagement panel is well on its way to being formed. In addition, every year, except in a COVID year, we do an educational community forum here at Nemours called the Juvenile Arthritis Day. And there will be a larger pool of parents then, and I will also solicit information from them. We do plan one for this fall of 2022. My references are here, but I think they went out beforehand. And my research contributors, Dr. Sullivan, who is the chief of immunology at CHOP, and then lots of other wonderful foundations who have funded this work, especially the Delaware CTR. And of course, many of you may know Richard West, who passed away sadly earlier this year. He was working on the flow cytometry for us and was very, very helpful in moving all of the flow work forward. So I also wanted to thank him. So, believe it or not, that's all I have, Dr. Pappas. But I can stay if I can stay if there's questions, if there's anyone who hung on this long.
Thank you so much. Your enthusiasm for juvenile arthritis is infectious and wonderful.
Love it.
Thank you.
Thank you.
We'll see if there's, I actually have a question. So you mentioned pain as being like a factor for kids with juvenile arthritis. Can you talk a little bit about what is known about pain and pain management and how that sort of tracks as a child grows into adolescence and then young adulthood?
Yeah. So it can go many different ways. It's very interesting that you say that. So some kids come in. I've had patients come in, the MRI is terrible, the wrist doesn't move, and they're like, no, I play lacrosse. Or their ankles and knees are swollen, and they play soccer, and they don't want to be stopped. They're like, no, it doesn't hurt, but we know there's damage going on in there, so we have to treat it. Unfortunately, they more often have this achy, stiff feeling that over time wears them down. Unfortunately, patients with arthritis or any other chronic condition can develop chronic pain, right? So if you're always uncomfortable and you sleep poorly, which any of us has done this, after 3 days, things start to hurt and you don't even have arthritis, right? If you sleep poorly for about 3 days straight, you're like, oh, I ache. So if they sleep poorly, then and their joints are swollen and stiff and they can't exercise, they start to develop chronic pain. So often we do see secondary pain syndromes develop in adolescence, especially if their arthritis is not well controlled. The little kids, they come in, they're playing, you see all these swollen joints, you treat them, they run and play. They couldn't care less. They're like, I don't care, I feel fine, I'm gonna play. If you can't get their arthritis under control and they get kind of sick and tired of everything aching, you see more pain, and we start to see this overlap with secondary pain syndromes, depression, because they're different from their friends. And so we actually employ here our we do lots of PT, we do lots of pool physical therapy because it's very nice on their joints. We don't take them out of something they love, but we hope they're not a ballerina on point or a football player. But if they already love that, we don't take them out of that. If they haven't committed, we push them towards swimming, right? Because it's so lovely for your joints. And we employ what we have here is called integrated pain and wellness. So we have psychology and physical therapy working together to help kids function and live their lives despite the pain. But we do use a lot of PT and a lot of psychology when needed. I don't know if that answered your question fully.
No, yeah, that's great. And one follow-up, do you know about the rates of access to care among kids with arthritis? I'm sort of thinking about kids who might not have insurance or low income, or, you know, what does that look like? And
so here we have a glut of pediatric rheumatologists, right, between us and CHOP and St. Chris and Hopkins, but there are some states in the U.S. who don't even have a pediatric rheumatologist, and so patients are driving 4 hours to another state, or they're seeing an adult rheumatologist. And the adult rheumatologists from Cooper and TJU come here for a month, and they see 2-year-olds with us. But that's not a huge part of their training. And I can't blame them because I'm not comfortable doing adult rheumatology. Many adult rheumatologists are not that comfortable with the exam of a 2-year-old. And so I think more of our problem is lack of access due to lack of trained pediatric rheumatologists. There's only about 250 in the entire U.S. And so there are states with no one. And so I think that I worry more about access. Here, we have strong social work. The patient, I do have patients, of course, who have trouble because they can't pay for gas, right? So we call social work. Sometimes the hospital has an Uber take them here, or it gives them transportation money, or if they have insurance or state insurance program, there's transport. So we really help them get really plugged in. But I am sure there are patients who cannot come, and it's just not a priority, right? If they're trying to go to work and feed their family, doctor's appointments, even taking off for my own child, you're like, that's a half a day. Does someone really have time to miss work and come to doctor's appointments? So there's a myriad of problems. And hopefully the patients who we at least become aware of, we can try to plug in and keep in the system.
Awesome. And then my final question, what's your timeline, or what do you think the timeline would be for the development of a biomarker, either the biomarkers you're developing or others to?
Well, I'm hoping within the next year to have a very nice panel that we're finally saying, okay, stop looking for more. This is a good one, and validate it as a Luminex panel, which is what we're putting them on now, is on Luminex, which is working very nicely, actually.
That's awesome.
I want to say a year, but don't hold me to that. Is this recorded? Okay. They're going to say,
it's recorded now. It's recorded now.
Right. Where's your panel? It's been a year. So let's hope.
Awesome. That's awesome.
All right. Thank you so much. I appreciate the questions. It's very gracious of you.
Yes. Are there questions from the audience? Can I ask one final question? Actually, it's been on my mind. So with COVID, there was a lot of discussion around drug availability, especially for people with, and I saw some of the drugs that I think you classified them as DMARDs, like, did you experience that either here in this area or nationwide amongst pediatric rheumatologists?
Yeah, so two problems. One, hydroxychloroquine or Plaquenil, as you know, 99% of lupus patients on it, and some patients with JIA are on Plaquenil because it's a nice adjunct for stiffness. So patients had difficulty getting it in the early year, maybe 2020, and then that improved. And then tocilizumab, which is Actemra or anti-IL-6, is currently being used, of course, for acute COVID pneumonia. And so we, at the beginning, we switched, like basically our inpatient pharmacy said we can't get it for infusions. And so we switched the majority of patients who were on IV tocilizumab or IV Actemra to another form, either sub-Q Actemra, which then later there was a shortage of that, or to another biologic medication. Now they caught up manufacturing, we've been able to switch patients. If they did beautifully on their other med, they just stayed on it, but some were like, no, this isn't working, the IV tocilizumab worked better, and so they went back to the IV. And now we can get it without problem. As you know, the IL-1 blockade, specifically anakinra, IL-1 receptor antagonist, is used for MIS-C, the multi-system inflammatory syndrome in children due to COVID. There doesn't seem to be a shortage of it, which is good. But you use it for very short time, like maybe 3 days, that kind of thing. So it doesn't seem to have affected it. The supply of anakinra seems to be fine.
That's good. Yeah, it's fascinating. It's fascinating what happened with COVID.
Yes, yeah. So thank you so much. Well, I know I went over a little bit.
You were a few minutes over, but thank you, Dr. Brescia.
Thank you so much. Thanks everyone for your attention.
Thank you.
Okay, I'll stop sharing.
Enjoy the day, everyone.